Good morning. How does that sound? Okay. I have kind of a soft voice, so I really need a microphone. I am Lauren Ambrozic. I am the Executive Director of the Colorado Prevention Alliance. Thank you all very much for taking time out of your busy schedules to be here this morning to talk about social determinants of health. And I wanted to thank Children's Hospital who gave us this space today. They're going to be holding a meeting with their internal staff this afternoon with Dana Long and her team. And we coordinated this initially for the Children's Hospital folks, and they gave us the space so we could host all of our external partners to have time with Dana and her team as well. So thanks to Heidi, who I thought might be here this morning, but we'll thank her this afternoon. So this whole conversation started for the Colorado Prevention Alliance, at least, well over a year and a half ago, when we were in focus groups looking at issues related to diabetes and depression. And we had community members and patients who said, yes, I know I need to eat better and I need to eat fresh fruits and vegetables, but the food pantry I go to doesn't have those. And yes, I know I need to go to the pharmacy to get my meds and I need to follow the specialist, but I don't have a car and I don't have money for the bus and I don't really have money to make it to the end of the month. So instead of the issues we thought we were going to find related to diabetes and depression, we found lots and lots of stories around social determinants of health. And so our board became concerned about how we could be engaged in that conversation. And as it turns out, many of you in all these walks of life are really concerned too, from the mental health and behavioral health folks to our communities and our community organizations, 211, our clinicians, our health systems, and our health plans. So I'm not going to spend a lot of time talking about what led us to today. I'm just going to give you a little bit of a synopsis because I really want to focus the time on the subject matter expertise that we have with us today in Dr. Dana Long and in Matt and Jeremy, who are the technological wizards behind the curtain of the demo that you'll see later. But just suffice it to say that there's been a lot of work over the last year and a half with large convenings of 50 to 60 people who have met several times, smaller work groups that have come together to discuss all these issues, and multiple smaller meetings across communities and organizations as we have talked to partners. And the collective voice has said it would be really great if we could find a way to connect our patients and people who need these services in a reliable and consistent way to community resources. So we have just set about trying to figure out how and whether it's feasible to do that. About 9 months ago through Children's Hospital here, we became connected with Dana, who's been an incredible thought partner, and who has developed a system at Children's Hospital in Oakland to help her patients and their families connect to community resources. So we invited Dana here today to talk about not just the demo of that technological platform, although it is cool, but also about all of the issues that we all of you are dealing with that are as important around workflow and process and training and screening and cultural humility and privacy and how does this interact with an EHR and tracking and those kinds of things. So we wanted to spend some time showing the system to you, but also having a conversation about how they were able to create this system that works exceptionally well in their hospital and in a consortium that's around their area too. And a little bit about how we might think about bringing this to Colorado and whether and how that seems feasible after we all sort of understand what the FindConnect system is. And we have used, FindConnect is Family Information Navigation Desk. Did I get that right? That is a system that's in Children's Hospital in Oakland. When we've talked about potentially bringing that here, we've called it Colorado Source. So many of you have heard the term Colorado Source. So just so you know, we're sort of talking about the same thing. So let me tell you a little bit about Dana. Actually, let me tell you a little bit about the agenda before I do that. Just so you know, this is a fairly informal presentation. We'd like for it to be interactive. We'll talk about several different kind of buckets of work We've talked about screening, we've talked about evaluation of data, working across silos, resource management, follow-up, and case management. These are kind of the big areas that we know we're all trying to figure out as it relates to how to deal with social determinants of health in various clinical situations. So we'll have Dana talk for a little bit about her experiences, we'll have the demo, and then we have a fair amount of time for discussion. But we want this to be interactive in the meantime, so there are index cards, and we'll probably pass those around a little later. You can write questions on there, but we'll pass around the microphone as well. Dana is probably the most persistent and passionate person that I have met as it relates to social determinants and making sure the people that she serves get access to resources. She also has quite the list of accomplishments. I'm going to share some of them with you. She's a pediatrician at University of California, San Francisco Benioff Children's Hospital in Oakland, who developed and began the FIND program. She is the medical director at the Center for Community Health and Engagement. She's the co-founder and medical director of the Family Information and Navigation Desk and FIND. She is the UCSF Benioff Children's Hospital Oakland spokeswoman for the Too Small to Fail, Talk, Read, and Sing initiative. She's a steering committee member of the first 5 Alameda County Help Me Grow. She received her BS from Stanford in biology and a BA in African and American history, and she attended medical school at George Washington University. And she completed her residency at UCSF Benioff Children's Hospital in Oakland. That gives you a sense of her academic prowess, but the video will show you this brief. Will give you a snapshot of FIND as well as Dana.
Everyone needs care, but if you really want to make an impact on a group, you really should look at the whole population of the survey. It used to be that you worried about if the ear infected or is a child with a fever and our immunizations up to date. Those are all important things, but is there a home? Is there food?
The definition of population health is actually very simple. How do you make an entire group of people, an entire city, an entire region as healthy as possible? When you walk through the halls of our hospital, there's definitely something palpable. Something palpable about the dedication of the staff. From the physicians to the registration folks to the environmental service workers, I guess it really comes down to love for the people and the work that we do. Put it in your mouth. My name is Dana Long. I'm a pediatrician at UCSF Benioff Children's Hospital, Oakland. I am the medical director for our Center for Community Health and Engagement, and I'm an innovator. The clinical work that I do in my research focuses on this concept of social determinants of health, where a child eats, sleeps, plays, goes to school, and these environmental factors drastically, profoundly impact health outcomes. Kids that grow up in poverty are more at risk for obesity, for asthma, for diabetes, for learning issues, for mental health issues. We are addressing those root issues and thus improving population health.
The work that Dana and many others that are here doing are catalysts for starting that change.
They've been going through this illness or sickness and stable form. I want to make sure that they have everything that they need, that they learn how to advocate for themselves, that they learn how to ask a question. Things that have been handed to them. If it's sour, make lemonade.
I think what we're trying to achieve is how to actually be able to give everyone the opportunity and the chance to reach their potential. I am part of this community. I live in Oakland. I am a mother. I am a woman of color. I am the community. My oldest is almost 12, and then 9 and 4. I would define health as wellness. Our hospitals have been in this community for the last 100 years, and we plan on staying in the community for at least the next 100.
Amid 1,000 maybes and 1 million no's, we believe in the profound and unstoppable power of yes. UCSF Benioff Children's Hospital, redefining possible.
So I'm really, really honored and happy that Dana's here, and we'll turn the mic over to Dana to talk more about the program and Oakland Children's Hospital and make sure we're
Thank you. And you are wired. Thank you so much, Lauren. That was a lovely introduction, and I'm really thrilled to be here, you guys. I recognize that everyone in this room has been doing a tremendous amount of work on thinking about how we can improve health outcomes for everyone, and I'm honored to be able to share some of my work and help to spearhead the conversation that you guys have already started. It's a really good thing I have this tech crew here to help me with all this feedback. Okay, so to get started, we have a number of different goals today. The first is I just want to tell you a little bit about my work environment so you can understand where this work came from, what my inspiration, what my impetus is. I'm going to define social determinants of health just to do some ground setting. I'm going to talk about how do we actually integrate into clinical flow? What are some of our research results? We're going to illustrate why FindConnect has helped us to build capacity and to really implement system change. And then I'm going to switch it over to my partner, Matt Espinoza, to do a demo of the platform for you. So I know Children's Hospital in Colorado is a really huge facility, and I think there are lots of similarities between my hospital and this amazing place. One of them is that your hospital is beautiful, and I actually hope that one day our hospital will be as beautiful. So I work at Children's Hospital Oakland. We are a freestanding community hospital. We've been in place for over 100 years, and we recently affiliated with UCSF, and so now we have an academic partner, but I was at Children's long before this affiliation, and there is definitely this, as the video said, this palpable feeling of dedication that we have, and we are learning what the value add is to an academic institution to be so driven by community health, and it's been a very interesting process, helpful to both parties actually. We have 190 beds in our hospital, and altogether we have about 260,000 patient visits a year. We run a federally qualified health center, and we are actually the only HRSA-designated SQHC that just sees children. And within our SQHC, we have about 36,000 patient visits. 98% of our patients live below the poverty level, and 90% of our patients are also people of color. So I am the medical director of a new entity. It's called the Center for Community Health and Engagement. And interestingly, with this affiliation and merger that we had with UCSF, it was really important to us that we keep our grounding and our authenticity within our community, and that we don't lose that as we sort of join with this ivory tower. And so hence we launched the Center for Community Health and Engagement, and our entire mission is focused on how to achieve health equity across the board for all children. And we do that with the community at the center of everything that we do. And so we actually are running our community benefit program for our hospital. We do policy work and advocacy, so the Director of Government Affairs and Relations is now part of our center. We do a ton of research, and that's sort of the piece that I keep. We do program development, we do workforce development. And we also hold convenings just like Lauren and Ralph are doing today, so it's really exciting to be here. First and foremost, though, I am a clinician. I'm a practicing pediatrician. I work within our federally qualified health center, and I now am old enough that I'm as old as the grandparents that I see. And even though I have a 4-year-old, most of the people that come in with 4-year-olds are actually those kids' grandmothers. I don't try to make too much of that. And I work in our asthma clinic, and I also work in our emergency department. And so this is one of my patients. This is Aisha. And Aisha is 6 years old, and I actually met Aisha for the first time when I was working in our urgent care, and I found out that it was her 4th visit to our urgent care for her asthma this year. And she was brought in by her grandmother, and she was definitely wheezing on her exam. She was prescribed steroids, and then I followed up with her in clinic. And when I followed up with her, the grandmother hadn't started her daily regular medicine. She was still wheezing on her exam. And the resident doctor, we're a training hospital, so we have 90 residents a year. We're one of the larger pediatric residency training programs. The resident was really taken aback. Oh, I just don't understand why she's not taking her daily inhaled corticosteroids. There was no system for the resident to even really think about these larger factors that were impacting Aisha. The fact that there was mold in her home, that her insurance had lapsed, so she didn't have health care insurance to pick up her medications, that the grandmother smoked, that there was a tremendous amount of stress in the family, that the father was just incarcerated. The resident wasn't getting the answers that the resident wanted about why she was taking her medicine because the resident didn't have the tools and capacities in order to ask the right questions. And quite frankly, if you don't ask the right questions, you won't get the right answers. And so it really led me down this journey of how do we best treat Aisha? Because honestly, prescribing expensive medicines that she's not picking up is not making her better. And the medical system was failing her, and it was also failing me as a provider because I wasn't following through with my commitment to make children well. So what are social determinants of health? My definition is so simple because I like to keep things simple. So my definition of social determinants is that it's where a child eats, sleeps, plays, and goes to school. And acknowledging that these factors profoundly impact health. So these pictures are actually pictures that I took of Oakland. So the picture of the houses are where I live, up in the Oakland Hills. And then these pictures of the tent encampment are right on the freeway. These statistics are from our county health department, and I'm pretty sure that if you guys were to look at your Colorado statistics, they would be the exact same. So compared to a white child that's born in the affluent Oakland Hills, an African American child that's born in the flatlands can expect to live 14 years fewer. And know that between the flatlands and the hills, there are 7 miles. That's it. You could run, if you were actually a runner. You could run between the two. And for each mile, there's a difference in life expectancy of 2 years. How is this okay with us, right? These are children that we see every day. And if we aren't actually making a difference in their health outcomes, then we truly are not improving population or preventative health. So compared to a child that lives in the affluent hills, a child that's born in the flatland as an infant is 2 times more likely to be low birth weight. Those of us that actually see newborns know that rates of preterm birth in this country have not actually drastically changed in almost 2 decades. And we also know that a woman like myself, a well-educated African American woman, my chance of having a preterm birth is as high as a poorly educated, not even graduating from high school Caucasian. And why is that? Why are we not even moving the needle slightly on preterm birth? As an infant, that child is also 12 times less likely to have a mother who graduated from college. As a child, that kid will 13 times more likely live in poverty, 4 times less likely to read at grade level. So for those of you that know about 3rd grade reading level, you know that it's highly predictive of high school graduation rates. And more we're looking at 3rd grade reading level as a proxy, not only for educational outcomes, but for financial outcomes. And as an adult, that child is 5 times more likely to be unemployed and 3 times more likely to die of a stroke, simply because they're born 7 miles apart. So as a healthcare physician, we know this, right? Like, we see it every day. And there was a report that was put out by Robert Wood Johnson called Healthcare's Blind Side. And what that report said is, great, 4 out of 5 physicians say that unmet social needs directly lead to worse health. We all agree on that. 4 out of 5 physicians say that social needs are as important to address as a patient's medical conditions, and this is even higher for physicians that work with low-income urban communities. And at the same time, 4 out of 5 physicians do not feel confident in their capacity to meet their patients' needs. And this is where the gap is. All of us have the best intentions, and we all work with committed, wonderful colleagues, but we don't have the tools, we don't have the system, we don't have the capacity. And when I started to dive into this work, the comments that I heard were really startling to me. The comments were, we don't ask because there's nothing we can do about it. We don't ask because, quite frankly, Dana, you're not going to solve poverty. Our plates are already too full. We are already overwhelmed. So as we started to embark in this work, we really hold up these principles of cultural humility. And we have to understand these principles deeply in our bones in order to be effective. These principles were developed by a wonderful mentor of mine who I love dearly. Her name is Dr. Melanie Turbalon. She was actually a pediatrician at Children's Hospital Oakland, and she published the first groundbreaking paper on the difference between cultural humility and cultural competence, starting in 1998. The principles of cultural humility rest on 4 tenets. So the first tenet is that we have to have a lifelong commitment to self-evaluation and self-critique. Essentially what that says is that when we are working with diverse populations and diverse communities, we have to know ourselves. We have to own our own stuff so that then we can actually be present to help other people own their stuff, right? Like, this is so basic. The second is that we have to really readdress the power imbalances that happen in the actual exam room. We have to recognize the difference and the influence of power and privilege and what our role and how we actually are seen in our community. The third is that we have to listen to our community. We have to listen as if our whole body is an ear. And the fourth is that we have to advocate for accountability, not only to ourselves, but to the communities that we serve. And it is because of these principles that my research has been so successful. So this is just a cartoon that I think is really funny. It says, I'm right here in the room, and no one even sees me, or no one even acknowledges me. So starting in 2012, we started to ask ourselves, so what questions do we ask? Where do we even start? Who asks the questions? What will our providers think about these questions? And what will our patients think about the questions? And so, because we are scientists, we decided that we had to do a randomized control trial on just figuring out what the questions were that we were asking. And so I've been working in our emergency department since I graduated from residency. So we decided that would be a good place because I had a lot of buy-in from the rest of the staff there. We randomly approached over 700 families, and we randomized them to 2 arms. So one arm was a control arm, the other arm was our treatment arm. And we randomized them so one arm received an in-person interview from a bilingual, bicultural navigator. The other arm was randomized to a tablet. This was before I met these fine tech folks over here. We randomized them to a tablet that had both audio and visual in English and Spanish to ask the questions. And then we decided, well, we want to ask some questions about basic needs, food insecurity, housing instability, access to childcare. But then we also wanted to ask questions about mental health. Are you concerned about your own mental health or the mental health of your child? Are you concerned about violence in your home? Are you concerned about immigration? And the first thing that we found that was shocking was the overall disclosure rate within our community. And so what we found is that almost 60% of our families endorse food insecurity. Almost 60%. And you have to understand that even though we have an FQHC, our emergency department is the largest in the region and it's open to all comers. And so our payer mix in the emergency department is about 70% are on public insurance, the 30% are private pay. Almost 60% said they ran out of food at the end of the month. Over half were concerned about the safety of their child, and a little bit less than half were concerned about the mental health of the primary caregiver of the child. This is an ACE for those of you that know about adverse childhood experiences. Right there, over 50% of our population has at least one ACE. And then we do live in the Bay Area, so 44% were concerned about their housing. People had no idea the depth of need of our community, and they said that we couldn't ask the question because patients would feel uncomfortable. Well, actually, unanimously, patients wanted to talk about this issue. Unanimously, they were like, wow, no one's ever asked me those questions before. And the interesting thing is, since I work in the emergency department, occasionally I would go into the rooms and I would ask the questions. And I feel like I am a pretty well-intentioned physician. I in the same color as a lot of my community. And you know what? I didn't get the same answers. There's something about the fluidity of dialogue that happens when you deal with power and privilege that makes it so that community wants to talk to community. And so the people that families did talk to were the bilingual, bicultural community workers that we had working with us, not me. And then what we also found is that although disclosure rates were similar across the methodologies, we found that when it came to very sensitive issues like mental health and interpersonal violence, families endorsed more honesty on the tablet. So this led us to our next study. Okay, so now we have an idea of what questions to ask. So now what are we going to do about the answers, right? Like, that was the hard part. What are we going to do about interventions? And so we formed a consortium across the Bay Area that included us as founding members. It included what is now Zuckerberg San Francisco General Hospital. It included our county hospital, Highland Hospital. And we all got together over several late nights, and it usually was in someone's living room. And we started to talk about, so what are the interventions? And so we decided we should do another randomized control trial. And this time, it was a cross-department, a cross-bay initiative. And so we recruited families from both primary care and urgent care within Children's Hospital Oakland and Zuckerberg General Hospital, which has a slightly different mix. We have a lot more African Americans. They have a lot more Latinos in San Francisco. It's over by the Mission District. We asked the same screening questions that we asked in the iScreen study. And this time we randomized families into two arms. One arm, because we had some ethical issues with our current standard of care of medicine, we thought it was unethical to actually ask questions and no answers and not provide any intervention. We actually gave families 2-on-1 cards. So we gave them lists of resources. And then the next group, we not only screened them, but we actually had a navigator, a community worker, sit with the family, prioritize the issues, and acknowledging that families are experts in their own lives and families are their own heroes, we said, okay, how are you going to prioritize those issues? Let's actually sit and partner and do this together. And I think it's very rare in this day and age that we actually do what we say we're going to do. And so our results were really humbling even to us. What we actually found, and the power for this study was mind-blowing. We decided that we had to overcompensate, and so we recruited almost 2,000 families because we wanted to be able to show without a shadow of a doubt that the data is providing evidence for us to make real change. And what we found is that we were able to do what we set out to do. we're able to actually satisfy, resolve at least one major unmet social need. And not only did we do that, but when we did that, we improved child health outcomes. This isn't an expensive vaccine or an expensive antibiotic. This is getting a child's food improves their health. And so for us, the next frontier is, so we figured out that if you can satisfy a patient's basic needs, we can improve their health. But where does mental health fit into all of this? And so how many of you guys have heard of the ACEs study? Okay, so the majority of you. So as you know, the ACEs study was a study that was jointly funded by the Center for Disease Control and Kaiser in San Diego, and it was mostly for middle-aged Caucasian white men. There's no prospective pediatric screening tool that's validated, and all the questions that we ask that have been put into FindConnect, we really want to use validated questions, supported by the research. And so we decided that there's none in existence, so let's do it, right? And so we currently are in the process of creating a validated prospective pediatric ACEs screening tool that adds and collapses to some of the initial ACEs categories, which are abuse, neglect, and household dysfunction. We've added on social determinants of health questions, as well as questions about experiences of discrimination and violence. And we currently have already finished our initial pilot. And what is really surprising to me is that, again, families are saying, yes, they want the providers to know the answers to these questions, but it's actually when we do the cognitive interviews of the providers where the hesitancy is. Well, I'm not sure I can actually deal with the answers. And so, again, we are facing, our evidence is telling us that we really need to have these system tools to support all of us, and that our families want to talk about these issues. So what is our North Star? What is our big vision here? Our big vision is that we want to be innovative. We want to be able to create clinical programs and build capacity that can disrupt the link between adversity and poor health. And we know that every child has the right to succeed. Every child has the ability to reach their optimal developmental trajectory, no matter what that trajectory is. Yet when there is adversity, whether it's from lack of basic needs or mental health issues, that trajectory goes down. And so as the health community, how do we build a buffer in order to allow all children to succeed? And I know there are so many different models of this, you guys, and I just want to be cognizant that everyone in the room is doing good work, and what we are offering is one solution, and there are many. So the way that we define FindConnect is that it's an innovative solution that empowers patients, care teams, and communities to collaboratively address social determinants of health. And the way that we do that is really starting at the basics. How do we actually practice team-based care? Acknowledging these principles of cultural humility and power and privilege, how do we actually, as a team, focus on caring for our community? And then change the healthcare system from within to really go upstream and ultimately to improve population health and achieve equity for all. So the goals of FindConnect are to make this really simple, to make it really easy. And it's a big dream of mine to have this vision and then to be able to work with technologists who can say, yeah, I can do that for you, Dana. Not very many people experience that in their lifetime, and it's really cool that we were able to build this. And so FindConnect offers a suite of tools. So the first is that we have evidence-based needs assessments that come out of a really hard-fought research battle. We are creating action plans, and the action plans are all about partnership, right? It's about sitting down with families and saying, how do you want to prioritize these issues? Let me work with you to create a plan. There are things to do for both of us, and then we need to follow up. There's a knowledge base, and for me, a knowledge base that is given to a family via a warm handoff is worth so much more than just an inventory or directory of resources. I would rather have 20 really good resources than 200 resources where the phone number doesn't work, there's no name for the contact person, and I can't actually sit down with the family and call right then and there. So we built a knowledge base working within our hospital with our social workers, with our home-based case managers, with our nurses, in order to say, hey, what resources do you use? And that was an entire process as well. We had research interns work with our departments. Where are your resources? Oh, they're in my head. Or they're in this file on my desktop that only I have access to. Or they're in this binder. Or I just don't know. And so working together to actually galvanize everyone to put their resources into one platform was a really big deal for us. And then we also want to follow up with families so they don't fall through the cracks. The automation, it provides for scalability and outcome tracking, and I really like data, so it allows for quality improvement and evaluation. And then lastly, there's a really large training component that comes with these conversations, a training component on how do you actually work as a team, how do you integrate into flow, how do you embrace these principles of cultural humility when addressing social determinants of health. So the platform itself has several different features. So one is customizable for every community. It has these algorithms, and so just like as a pediatrician, I know how to treat asthma because I know what to ask in my history. I know what to look for on my physical exam. I know what to look for when I do spirometry, and then I can create an assessment and plan. Why? Why don't we have the same thing for food insecurity and housing instability? And so we started to use the same academic rigor and say, okay, so is it that your child, are you hungry? Is it that you don't have enough food in general? Is it that you need food today? Are you signed up for food stamps? Are you signed up for WIC? Do you know where your food bank is? To make it rigorous and standard is very important. We also are HIPAA compliant. The platform will run on any browser. So we've had a lot of milestones to date. We were actually the first randomized controlled trial in the country to look in the pediatric setting at addressing social determinants of health and tying them to health outcomes. We started piloting our technology within clinic in the summer of 2015. We completed a proof of concept, and it was actually vetted through our School of Medicine Information Services unit to ensure that it was HIPAA compliant. We just finished our second pilot and are really excited about our product. And we are launching into another randomized trial this fall where we're actually going to use FindConnect and then look at biomarkers. And so look at telomere length and cytokine and different inflammatory markers and see how those correlate with each individual item that's endorsed, and then pair it with interventions and see how we can mitigate those biophysical profiles. We are gathering resources on an ongoing basis, and we are onboarding staff. With our EMR integration, so we were really fortunate at Children's Hospital Oakland that because we're a county hospital essentially, we didn't actually start using EMR until 2014, which is like so embarrassing because Kaiser had been using it for a decade before. But because I was there during the build of our EMR, we actually were able to integrate some of these screening questions into our electronic medical record. We're able to make referrals to the Find Desk through our EMR. And then the action plans can get imported into the notes. We found out recently that for Epic is our EMR, but I think this is for EMR in general, that it satisfies meaningful use requirements to build API bridges. And we really are focusing on sustainability, on integrating into clinical flows, and to really shifting the paradigm of medicine. We want to start billing for services rendered, and we are in a special situation where we're at FQHC, so we get special government rates for our Medi-Cal reimbursement, but we really want to look for states and institutions that are willing to start using billing codes for protected factors and for screening. And then ultimately, we are talking about forming an ACO and using FindConnect as a platform for data management, population level health, and follow-up. So I have the great privilege to pass this over to Matt Espinoza, who is a genius when it comes to technology, and he helped us to make this a reality. So thank you, Matt.
Matt Espinoza, CEO of Diggable. we're a creative technology company. We've had the absolute privilege to work with Dana and her amazing team at UCSF Benioff to build FindConnect. We've been also talking with Lauren and Arthur, so you may have heard this referred to as Colorado Source. So just make sure that we can see this here. Okay, so what I'd like to do is take you through the system. We're going to go over some features and functionality. We're going to go through the enrollment process for the caregiver or family, go through the needs assessment questions in some detail, and the knowledge base, talk about the knowledge base features and functionality there. So when you log into the system, you have a dashboard here, which gives you an overall snapshot of the system. The information here at the top is specific to UCSF Children's and is updated in real time as the system is used. We have the priority needs identified. As you can see, activities, foods, and child development are the top 3 needs that are being identified. The top 5 reference resources gives you a look at which programs are being referred to families. And what good is the information if it's not kept up to date and accurate? So the system can expire the knowledge base articles, either itself through a timeline or by navigators if they identify that there's information that's out of date and needs updating. The top 5 enrollment zip codes here are shown via a map, as well as the zip codes listed on the left here. So we'll jump over to the enrollment process. And that begins by collecting some information about the caregiver, the family, or the child. First, last, and birth date. So we're not going to put anybody into the system now, but we've got a record that's been developed for demonstration purposes. So after you collect that initial information, you're taken to the enrollment process to further collect information on the patient, the caregiver, or the family. So the location, where they are, the date of enrollment, the navigator who's assigned to the family, which we can hand off to other navigators within the system. And that functionality I'll go through later in the demonstration. Any extra information as far as their name, phone number, referral method, caregiver race, when you can add them over here, and they'll add to the right, ethnicity, income, and listing of the children here. The enrollment process is continuing to the needs assessment survey, and this is where Dana's years of research, clinical trials, have been brought into this web-based platform in order to ask the questions. So the navigator identifies himself as the one working with the patient or the family, the survey location. This information here at the top, do you have access to MyChart? That's specific to California, but this is where some of the functionality can come into play. So it could be customized to Colorado. We have the needs listed here, which you can check off as you ask the family what their needs are that they'd like to identify. And we're going to go through some of these in detail, so beginning with food concerns. And all of this is dynamic, so as you're asking the questions and you're getting answers from the family, you can select yes or no, and we provide the navigator some information some verbiage to speak with the family about. So I'd like to share, are you concerned about running out of food before the end of the month? Yes or no? If yes, I'd like to share some information about the Alameda County Food Bank with you, as well as information about local emergency food pantries through the Food Bank Community Organization. There we go. So that's the verbiage we give the navigators to talk with the families about, along with navigator needs here. And this will drop down information that the navigator can give to the family or caregiver immediately at that visit. So Alameda County Food Bank flyer, emergency food handout, Kingdom Builders information, summer lunch program flyer. Continuing on, are you currently signed up for CalFresh, also known as SNAP, Supplemental Nutrition Assistance Program, which used to be known as food stamps, yes or no? If yes, we continue on. If no, we go to the next question. Is your child currently signed up for free or reduced school breakfast and lunch programs? Yes or no? If yes, have you heard about the free summer lunch program where your child can receive a free lunch every weekday through the summer, along with the navigator needs again? If no, since you're on CalFresh, your child is eligible to receive free or reduced school breakfasts and lunches. Have you heard about the, oops. Do you need food today? Very important question in regards to food anxiety. If yes, we can provide you with a bag of food today before you leave the clinic. If you are interested, we can also refer you to the food bank so they can arrange for you to pick up an additional food bag at a location and time that works for you. Are you or your child currently signed up for WIC? Yes or no? Do you have access to fresh fruits and vegetables? If no, did you know that the farmers market throughout the county offers a variety of fresh fruits and vegetables? And you can also use your CalFresh and or WIC benefits at some of the markets. I can provide you with a list of farmers markets that can accept CalFresh and WIC if you're interested. Continuing down to housing. Do you have concerns about unstable housing, including evictions, foreclosures, and or staying with friends and family? If yes, we'd like to connect you to some of our partners that may be able to offer some legal assistance and consultation. We'll compile a list of those partners for you if you're interested. Do you have concern about unhealthy living conditions like mold, pests, mice, excessive trash in your home? If yes, do you live in Alameda County and have your child ages 0 to 18 with asthma? If yes, we can refer you to Asthma Start, an organization that provides in-home case management for families and children with asthma if you're interested. Or we can also make a referral for medical legal services, and someone will contact you to set up an appointment. They may be able to assist you in negotiating with your landlord concerning living conditions. Continuing on to child's development health. If your child is under the age of 5, are you interested in a development screening for your child? Yes or no? If yes, has a doctor completed developmental screening such as an ASQ with your child at 9 months, 18 months, and or 30 months? If no, are you interested in doing a developmental screening for your child? Moving on to utilities. Do you need assistance with your utility bills, such as electric, gas, water, or phone? If yes, we allow them to list the ones they need help with. And if we asked, have you received a cutoff notice? Yes or no? And it continues on through diapers. At the end of the needs assessment survey, we ask the family, what are your 3 priority needs that we can assess today, which we can help you with today? And we select them down at the bottom here. So, saving that information, we'll continue with the enrollment process, which goes to family information.
And Matt, I
Yes.
just wanted to point out, as we talked to all of the team, as we've talked to the team, one of the things that can and would be customized if other organizations were to use this is that creating assessment piece and categoricism into kind of portaling into the system if you already have your own assessment. So we've been talking about that. So trying to give us a sense of what they're doing and then the kind of extrapolations in their system that just by the input is
Absolutely.
It's customizable.
Very customizable. And the needs that are identified down here at the bottom, we understand they can change over time, so we can go back and modify them. And we use Google Translate to do like translation to assist the navigators in case there are any language barriers. We have 3 in there now: Spanish, Chinese, Simplified, and Arabic. So what it does is it changes the entire needs assessment survey into a different language. So there can be a little assistance with reading if there's a different language involved. So continuing on, the family information, this is more detailed information about the family, their insurance provider, relationship to child, child's MR number, preferred gender, racial identity, ethnic identity, which is both from ethnic, the preferred language, current insurance provider, as I mentioned, and these are all customizable. So if there are one specific to Colorado, they can be added into the system without any modification to the platform. We give you that functionality. Street address, city, state, zip, patient's county of residence. All of these are specific to UCSF, but again, they can be customized to any region within Colorado. how to best be contacted, and then information regarding being contacted, along with the referral method and any other children and their birth dates in the household. Now move on to the action plan. During the needs assessment, depending on the answers that were given by the family or caregiver, that's where our system starts to derive resources that are relevant and can accommodate the family and their needs. So along the left here, we have a large amount of recommended resources by the system based on those answers, which we can add to an action plan over here on the right. So as you're adding resources to the action plan, you can then go inside and edit them and provide navigator actions, gave food handout, family actions, go to farmer's market. And so each one of those is providing little tidbits of information about what the navigator did and what the family is going to do. And these are all saved within the action plan. So when it's printed out, it'll have all the information there. So continuing on, the action plan. And this is where we prepare the action plan to be generated, printed out, or a PDF generated to go into an EMR system. The priority needs that were established during the needs assessment as the ones to be accommodated today are listed here on the left, the three: food concerns, housing concerns, and child development concerns. The resource information that was added to the action plan is listed in this column for all of them. The recommended actions, as I just went over, is information that the navigator is going to do and the family is going to do. Now, the referral instructions, this is pretty important to go over because what the system allows us to do is close the loop on the utilization of the resource, which is extremely important to determine if the resources are working. If they're not going, we can investigate why if not. So what we do is we establish a local area code phone number wherever FindConnect is being used. And with each resource, a unique code is generated within our system that not only identifies the family, but also the resource that is being utilized. So either the family, the caregiver, or the resource themselves can receive the action plan, send this unique code to our system, which will then tell us when the loop was closed and how much time has passed since leaving the find desk and when the resource was utilized. So again, that is unique for each one of these resources. So there could be hundreds of thousands of unique codes for each family, for each resource. We offer file downloads, PDFs, supplemental information, and resources that are added to the knowledge base when the resource is added to the system. This could be flyers, it could be instructions, it could be printed out. And we give them the ability to print out the resource individually, but also print the action plan or print all the related PDFs all at once. So just giving the navigator the ability to give the family or caregiver the information that they need right at that moment. Continuing on to follow-up. This is an area where the navigator can keep track of all the follow-ups that have been attempted or made with the family or caregiver. So down at the bottom here, follow-up 1 was via phone. The result was that we left a message. The message was, called mom to see if she had been able to get food from the food bank, left a message. The second follow-up was face-to-face. The result was a success. Saw mom in clinic, and she said that she had signed up for playgroup starting in October. So again, keeping track of follow-ups, very, very important. The summary view is sort of a storyline as to the family's path through the FIND system and contact with the team. So the date of the enrollment, any children that are in the family, their date of birth, the needs assessment, when it was completed, and the primary needs that were identified by the family. The action plan form was created, you can view it right here, and along with the follow-ups that were done. As far as handing off the family or caregiver to another navigator, we understand that this is a critical process. It is important that no information is left behind, no information is forgotten, and that the initiating navigator and the receiving navigator fully understand why and when. So as you can see, a handoff was made from myself to Jeremy. So within the handoff, you're able to list the reasons for the handoff. So this is due to preferred scheduling. The identification of all priority needs. So these were the ones identified and the questions were answered within the needs assessment survey. The priority needs, the top 3 that were identified are listed here. The action plan that was generated can be viewed or printed right here. The status of the case, so anything that we want the navigator to know, the receiving navigator. So Ms. Fisher wanted to be contacted on Wednesday after 1 p.m. Please make sure she gets to her first play group. And when the receiving navigator gets the family or the caregiver, they respond simply confirmed. When a handoff is initiated, our system sends an email to the initiating navigator letting them know that the initiation has begun. This is to make sure that in case it was done in error, they know immediately and that nothing falls through the cracks. An email also goes to the receiving navigator, which tells them a handoff has been initiated, and here's a little bit of information along with a link that will take you directly to the handoff so you can read and understand. So that wraps up the enrollment process. So we'll go ahead and jump over to the knowledge base where all these resources live and where they're entered.
Can I interject just one question?
Absolutely.
Well, I actually have several, but I'll just do one.
Sure.
Multi-family households. Do you just break them out as separate households every time when you're doing the enrollment process? So if I'm coming in and I'm in a household, but it's also my household and my sister's household, but we're in one household, I'm just trying to figure out how that enrollment process works, similar to multi-generational, right? Like, so my grandparents are living with me, they have different needs. Like my household has a need, but my grandparents have needs, and then my kids have needs. Would that still be under the same enrollment as a caregiver?
So the question is about family units and enrollment, and the entire family unit gets enrolled, and that's why the initial enrollment screen, you actually start with the patient that's in front of you, but then there's a section where you can list all the names of the people that live in the household or the caregivers of the child. And then when that child comes back, you can search for family by name. And so you can search for any kid or any caregiver that's already been inputted into the system.
Okay, thank you.
You're welcome. It's a really good question, and it's actually something that we had to, sorry Arthur, I didn't mean to joke. It's something that we had to think about a lot, about the recognition that families often have many kids, but many kids might have different biological sets of parents, and they might be living with an aunt or a grandmother. And so absolutely, it's that entire unit.
Perfect, thank you.
So this is the knowledge base, and we understand that this knowledge base will continue to grow over time. There are some programs that are all year, every year. There are some that are temporary, some very temporary, such as just over the summer. So we give you the ability to filter the program by name, the need type, subcategory, and this will give you an idea of the power of the system because we're able to tag these resources at a very granular level to identify them with just more than one tag, basically. So let's go ahead and go into one of these. And we'll take a look at the details of it. So when you enter a knowledge base article, we provide the navigator with the ability to add as much information as possible. As we talked about earlier, if the phone number doesn't work or there's no contact name or it's expired, it's not benefiting anybody. So we allow them to enter the program name, we identify who entered the information in the system, the status of the knowledge base article, the start and expiry date, if it applies, if it's a free or fee-based program, and if it is fee-based, how much is the program. So the program hours, a description of that, a brief summary, link to the program, the organization name, the contact name there, the contact phone number, and any additional information that you can give, provide the family or caregiver to look into this. There's also detailed information, miscellaneous information, and here's where the power really starts to show in the system. Program eligibility, these are all tags, so we can geolocate and get very granular with how we identify these programs. So as far as eligible counties are concerned, these are, again, specific to UCSF, but they can be customized very easily within the system without having to modify it. So as you identify eligible counties, you add them to the list, and this is specific to this resource. So eligible cities, eligible age groups, languages served, and the needs tag. So this is where the system is able to identify how these needs apply to the families based on the needs assessment answers. So again, as you identify needs, you add them to the list. along with subcategories, a very, very long list of categories. And knowledge-based entry file attachments, this is where we were showing PDFs within the action plan. This is supplemental information that can be given to the family or caregiver during the action plan. So you just add them, upload it, and they're stored here. And they can also be updated if a new information comes out. So very, very powerful tool to identify these resources within the region or the area. As far as reporting is concerned, since FindConnect can be done with a single organization or many, we're able to generate reports that are site-specific. Or we can generate a report that includes all sites, and depending on the usage and how much data there is, will determine the type of report that is run. Understanding that different organizations have different sizes, different teams that can use FindConnect. We offer very specific user-level management, from administrators to very basic read-only accounts. And this allows small teams to do a lot within the system with few people, or large teams to be able to distribute the effort across their entire organization. So anything from just being able to enter knowledge-based articles to only being able to enroll families, we can get very specific with the access. And this can be customized however the organization is structured. So I'll just give you an idea of the types of granularity we can get. So administrative tools, dashboard overview, these are all things that we can turn on and off on a per user basis. So if you needed 20 different user types, we can definitely accommodate that. And the age groups, counties, cities, this is all where you're able to modify the system to include or not include information that's specific to your region or your state. So again, just a nod to the customization of the platform without having to go through modifications to the platform itself. So that really rounds out FindConnect, and I really hope that we've shown some features and benefits that can be useful in identifying needs of families in Colorado. One of many exciting tools and excellent tools out there. So I'd like to open it up to questions to here in the audience and to those on the phone, if you have.
And we'll try to get a microphone to you guys if you don't just talk loud and you guys repeat the question. Kristen's also coming out and she's going to pick up index cards in case there's some question you want to ask that you don't have in front of you. We'll get another microphone over on that side.
I have two questions. The first one is, how does this information, and maybe it does or does not, get translated like into an EPIC chart?
Well, that is done on an organization-to-organization basis. We work with the organization and their EPIC team within to develop this EPIC bridge.
Okay. And then the second question is, you had mentioned MyChart earlier, so can the patients access all the information that they need to on MyChart?
Yeah, so if I can actually just speak to that last question, that first question first. So within our FQHC, our navigators all have access to the FindConnect system. They also have access to the EMR. And so it's pretty simple for them to actually import their notes and the PDFs that get generated from the action plans into the EMR. But your staff, at least for me, like they had to have access to both systems so they can actually work together. We currently are meeting with our hospital leadership in order to make it super seamless. But at this point, the way it works is that some of the screening questions are already integrated into our note writer for the physician templates. And then the action plans that are created get imported as a PDF. And then your second question was?
How do the patients access it?
Oh, so at this point, our research showed us that it was about this relationship of the community worker, the navigator working with the family. And so at this point, this is a tool that's meant to be used in a relationship. And so it's something that the navigator actually sits with a laptop or a desktop or a tablet and sits with the family and does it. We do have plans, and we started to talk to Lauren Arthur about this, about making a patient-facing portal. But we decided to prioritize sort of this relationship within healthcare before we do that aspect of it.
So if they had questions, would they just contact the navigator, like if something was approved?
Yes, and so on the action plan, it lists the name of the navigator and their contact information.
Well, we have the microphone, can we do one more and then we'll move down?
Okay. I was wondering, in your work with the community resources that these are referring to, did you have any capacity issues with actually getting the service to the client, or excuse me, the patient?
Capacity issues in terms of making...
Well, if you refer someone to, say, a food bank, would they ever have a waiting list, run out of food, because now there's a new, very large referral source?
Yeah, it's such a good question. And so for the food insecurity items, that was never an issue. The food bank, actually the food bank is looking, they have so much wasted food. It's truly amazing. And they have so much wasted fresh produce that they actually want more people to come to their food banks. The issue that we struggle with for capacity mostly is the housing issue, because there's just not enough housing. And so we are very clear that we can't create housing. We are working with habitability issues, and so we help when there needs to be remediation for issues of mold, or if there are true legal issues that we can work with our medical legal partnership on. We had contemplated taking housing out of the system because it's such a frustrating topic, I think, because people have these expectations that we can help them find homes, and it's a large policy issue, affordable housing for low-income communities. The one issue that we are able to sit and help with are for families that we know are sleeping on the streets tonight. And so if a family endorses that they're sleeping in their car or on the street, then we do actually call around to the shelters with the family.
Okay, but did you do any work with the community-based organizations before you started this whole process?
Oh yeah, so much of this is actually, every single resource, we actually reach out to that community organization and say, hey, we're FindConnect, we tell them about the system, and we make sure all their information is listed and accurate. And these are partners that we've had in our community for a really long time.
I can't see behind.
Yeah, one over here.
Hi. Is the team of users with access to FindConnect limited to the primary care providers and staff within your hospital, or is it possible for it to be expanded to include, say, a child care provider that does a developmental screening?
So I've always thought that Find doesn't necessarily belong in healthcare. It certainly started in healthcare, and so now it is the physicians and the navigators that are using the system. But we've been actively talking with our local school districts so that they can start to do screen with their family engagement officers. And I think ideally FindConnect should be in the community, and it should be sitting in the community-based organizations without a doubt. I would love to see that happen. And I'm very aware that a navigator can be anyone.
Got a question down here in the front.
I'll go ahead. So this is an amazing resource. You guys have done an incredible job. So 3 different questions. You mentioned 211 to start. And so I was wondering a little bit with all of the other resources that are, big infrastructure pieces that are already out there, is any of that feeding into or bi-directional? The next one is funding, and I think you might have mentioned it, but I'd love to hear a little more about how exactly you guys are supporting this. And then I think you made some reference to working with Arthur, but I was wondering what is the current, with Lauren and Arthur and team, what's the current investment with this resource in Colorado? And I'm going to... I know. And I was wondering... Then you can take it back.
You should have known, Lauren. Come on.
Why did I differ on you?
So I love all those questions, and I think that they're all really valid questions. And so 211 is a fantastic resource. When I first started to conceptualize FindConnect, it was really in 2011 and 2012. And so for the research, the control group for the study where we actually randomized families to get screened and then provide interventions. So 211 was actually the control group. It really should be called a case comparison study as opposed to a control study. And what we did is we went to our local 211, we went to their website and we downloaded their PDFs and we handed those to families. We were in conversations from 211 from the beginning, and what we discovered is that 211 is often operated differently depending upon the municipality, the county, the region. Our local 211 works on a platform called Eden INR, and they were really working on making sure that their resources were open, and they certainly were very supportive of being the back end of the system, so that opening up their API so we could draw from their resources. And at the time, they just didn't have the technical capacity to allow us to do that. But I certainly think that 211 plays a huge role in this, and we need to explore more how those resources could be the back end of the FindConnect system.
So the next one was funding.
So for funding,
Always a fun question.
Jeremy, Matt, and I, we put in a lot of late nights and blood, sweat, and tears in order to create this system, because sometimes you need to actually create it first, and then demonstrate the effectiveness of it using evidence-based tools. And so all of our funding at this point has come from money that I've raised through private philanthropy, but we're certainly working on looking at funding every day. And then for the question about how I'm working with Arthur and Lauren, I'm actually going to let them speak for themselves about that question.
You got the microphone over there.
Well, so, where to start with that? We have had a task force that was drawn from that really large group of folks.
That was drawn from that large group of folks that have been working on thinking about how to do this and thinking about all of the work that's happening in Colorado as well as what they're doing with FindConnect. And because this is a non-vendor solution, and because they've done such great work around training materials and the screening assessments, we've been talking a lot about how we might bring that here. But we are also well aware that there are the Accountable Health Communities grants and work that's happening. There are lots of pockets of ideas and perspectives about how people are addressing social determinants of health, which is why we've had these large meetings. And so, kind of just openly and transparently, we did put in a grant to the Colorado Health Foundation to support bringing Find here as a beta test and piloting it to figure out if we could do something across the state to provide these resources in a centralized way with lots of different partners. And what the Health Foundation has asked of us and several of our other partners with the AHCs and Help Me Grow and 211 is to convene again at another level to figure out how it's best to do that. So the short of that long answer is it's in process, and we still want lots of input on it.
Andy, does that answer your question?
I think that's all.
But that's part of why we wanted to bring Dana and Jeremy and Matt here, is that so we know what this is. And so when you walk out of here today, if you know what this is, then we can compare it to whatever everybody else is doing and figure out whether and how we can best do this. I'm going to pass it to Mary Jo.
Or actually, I got one up here.
Hi, Matt, thank you for the presentation. I see the purpose of the work you're doing. From my perspective, it seems like it's an unequal lift, that you're doing a lot of work that maybe departments of human services would be doing or should be doing in the state of California. Has the state approached you about this? Have you approached the state and maybe diplomatically demonstrated that we're doing the work you're doing? It makes sense that we do it because we have a lot of this flow through the hospital. We can capture a lot of this population. But we're doing the job we're not supposed to be doing, but it is encompassed in the work we do as healthcare providers. I'm not sure if that was a clear question.
No, I understand the question. I understand the question because I understand that I went to medical school and I was trained as a pediatrician. I was trained to deliver care, and I was trained to work at the top of my license. And the reason why this system was created was because of the huge dissatisfaction and my certain refusal to continue to work the way that I was, because I felt as if I was not using my skills and I was ineffective. And so I think that the question that you're getting at is a really large question. This work that is happening on the ground by us pouring all of our knowledge and heart and soul, this is work that needs to be part of a larger national conversation about how do we actually shift the needle on health equity, and how is our country supporting policies and supporting dollars for those of us that work in safety nets to continue to work effectively and efficiently. That's your question. And I think that the answer is that a lot of doors have opened for me because of this project, and what is always being asked of me is show me the evidence, show me the data. And so we went through this process where we decided that we were going to put a ton of academic rigor in order to show the data that by addressing unmet social, environmental, and mental health needs, you can improve health outcomes. It seems so basic, but the policy members weren't even willing to open up the seat at the table to me until I had the data, and now I do. And it provides a very powerful leverage point. And actually, Matt and Jeremy and I were invited to meet with HRSA in November to demo and show them the platform.
I think the way things are kind of working out here in Colorado is we have more of those kinds of folks at the table. We have people like HICPA and CDPHE and some of those folks, a number of the foundations who have come to the table and asked the kinds of questions I think that you're pointing to. It is sort of a diplomatic answer to say, yes, we're trying to do something that you've been trying to do for decades, and it is something that we want to partner with you to continue to do, because we have access at the healthcare level that public health doesn't have, and vice versa. And I think it's a really important partnership to really work on.
So I have a technical question and a workflow question. So for the technical question, one of the challenges is always getting data back from community resources back into the medical record in order to have that closed loop that the patient was taken care of. I was intrigued that you're using text messaging with a unique identifier, which really resolves the problem of interoperability and elaborate interfaces. So my question to you is, what level of specificity do you get from that unique text identifier back, or do you have to call and say, well, what did you really do with this number, and how did you really care for them, or is that just sort of like the next phase?
Yeah, as far as the text message coming into our system, it gives us a little bit of information, who the family is, what resource they're utilizing, and how long it took for them to utilize that resource since they've left the Find desk. So there is the ability to expand to more information. We'd identify what the resource would be able to provide us and the means they'd be able to provide it to us with. Because understanding that it's quite a lot to ask a resource to give the information specifically to us regarding the utilization of a family or caregiver. So, I mean, that's definitely something that we can work together with and develop in order to expand the amount of data that we're getting back.
I think you resolved a really challenging problem with a very simple, unique solution with the texting, so kudos for that. My workflow question is, Dana, you typically said that community wants to talk to community. So in a healthcare setting, how are we going to bypass that hurdle where we really have to have health providers at some level of their education, ask these questions. We can't just create necessarily in every single healthcare setting a panel of navigators. We might have to be using our MAs, our RNs, our providers. So how, can you just maybe go a little bit deeper into that? Community, talk to community, and in a healthcare setting, how are we going to?
Sure, and so this gets at a broader conversation that I know that my institution is certainly happening about team-based care. And we do a lot of Kaizens. If you guys do Kaizens, you know what Kaizens are. Kaizens are that Toyota model for lean startups, and Kaizens are everyone has a specific job to do, and that job is somewhat standardized. And so as we approach team-based care, it's who on the team is responsible for doing the screening. I completely think that it could be an LVN or an MA that does the screening. It has just to be standardized as part of their workflow. And I do want to say, I never make any assumptions about people and adversity, and I know that adversity crosses socioeconomic status and spectrum. And I think that it is possible to train people through principles of cultural humility to be able to relate to anybody. And so I think that as a healthcare profession, we certainly are compassionate, good people, and it is acknowledging power and privilege, and it is absolutely possible for physicians to start to screen if that is your workflow. I think it's just figuring out what your process is and making it standardized. Does that answer your question?
So I have another really granular question. I mean, really elegant solution and, you know, really innovative in how things are all connected. So can you give us a sense of what are the human resources required to have gathered the information for what I think you call articles?
Yeah.
In the first place? I mean, I really love the way you have built in some algorithms and some opportunities for people to say, wait, this organization doesn't exist any longer, or they changed their phone number, or they've changed their focus, or whatever. But what do you estimate the human resources are to make sure that the information you're using and providing to people continues to have integrity, and sort of how do you then scale that larger and larger? I mean, because that just becomes like another huge human factor. I'm not understanding that technology is particularly useful, that there's some real human capital that's required to both put the resources together in the first place. And you described sort of how you started, because we all know people with their notebooks and their index cards and their amazing memory. But then getting it in here, keeping it updated and adding to it.
Yeah, it's such a good question. There are a number of resource directories out there, and believe you me, I was not intending on creating a software or an app or befriending technologists, right? This all happened because I found that the resource directories that were out there were inadequate because they weren't granular and they weren't culturally responsive. And I also know that good people are doing this work every single day, and it's really important to acknowledge how hard the Department of Psychiatry or the Department of Orthopedics or the Endocrinology Department already are, and how they actually already have their own resources. So the human capacity is that for us, we have a lot of young people in our community who are looking for workforce development. And as the medical director for the Center for Community Health and Engagement, we have what we call the CORE. So CORE is Clinical Opportunities for Realizing Equity, and there are young people in our community who want experience working in the community, and a lot of them end up going into healthcare. And so we have volunteers work with these departments, and it actually didn't take that long. They would go to one departmental meeting, and they would have one person who was like their contact person within the department, and that department would just hand them the binder, or give them access on a thumb drive to that resource folder that was on their computer. And then the architecture is so very simple and clear that our volunteers could very easily plug in that information, and then they could make the phone calls to say, okay, yes, that resource is still open, yes, they offer it in 5 different languages. And so we had to depend on our community, depend upon these volunteers to work with the departments. But that's the way you get resources that are accurate and good, and it worked for us. I'm actually super curious to know how other health systems would be doing this. But we found that it was super important to vet every single resource, because we build trust with our families. And the last thing that we can do is give a mom who has 4 kids a phone number to a food bank and have that food bank closed or not there of the hours that she shows up.
I think there are a number of models around the country that, in the process of the work group work that we were doing, we saw that these different software packages had different models for doing this work. I think one of the ones that really stuck in my mind as we were doing it was the work that Health Leads was doing. And they were using graduate students updating and putting the information into the systems. So obviously, there are a lot of different resources within your community that you can use to do that work. I think in Colorado, it's going to be up to us to find which ways work for which communities. I have the thinking suspicion that here in Denver, one thing might work that might not work in Grand Junction or Sterling or La Vista. And so we're going to be, as we work through this, looking to see how do we adjust this so that it works for each of the communities that we're looking at.
Can I add something to that?
Absolutely.
So most of our volunteers are actually graduate or college students. You know, in the Bay Area, we have so many state universities and local universities that we're working with. We actually approached one college called Mills College, which is a smaller private, used to be all girls, but now it's a co-ed institution. And the provost was so taken aback, and this was starting in 2012-13. She was so taken aback by our work, because they actually created an entire major based upon this. And the major is called Equity, and it's an interdepartmental major that incorporates the biological sciences, the social sciences, psychology, health and human services. And I mean, it was amazing the way that she was like, why aren't we doing this? Why are universities and institutions not using this as a service learning model?
Hi Dana, you mentioned Help Me Grow in your introduction. How do you interface this with your Help Me Grow in Colorado?
Yeah. So, as Lauren mentioned, I actually am on the steering committee for our First 5 Help Me Grow chapter. And we actually just did a demo for them on Tuesday. And they are also in the process where they are forming coalitions of folks in order to really think about how Help Me Grow is going to start to address social determinants of health. And we are a huge thought partner for them. And I actually had shared information about all the papers that we published and the screening tools. And so we are arm in arm with them as they are going through their process. And we really want to be supportive.
Thank you, Dana. How often do the navigators enroll in programs that day versus just keep providing information?
The whole point is that they actually are sitting with the families and calling and doing the applications and doing the work right then and there.
Do they do that for SNAP, Nurse Family Partnership?
Yeah, they do. And so we actually got a grant from our food bank to be trained up to actually be able to enroll families in CalFresh. And so we can actually enroll in CalFresh that day. You know, the thing is that the enrollment, you need a lot of information. And so what we found that works best is that if families, we go through the qualifications. If they qualify, we actually printed out for families a very simple checklist of all the information, you know, birth certificate, social security cards, and then we schedule them an appointment at the Find Desk just to enroll in food stamps because it's a complicated process.
Hi, I'm just curious. You mentioned that those that used the tablet when you were testing it were more honest. What percentage of your clients or families use the tablet, and do you see any difference in their follow-up?
Yeah, it's a really good question, and I think that it's conflating a couple different things. And so the very first randomized trial that we did, we used tablets that were programmed in English and Spanish, and that was really just to find out what questions that we could ask. And there was more honesty on the sensitive issues being endorsed on the tablets. The FindConnect system in and of itself is meant to be used in partnership with a staff, a team member. And so families are not using the tablets on their own, they're using them in partnership with whoever the navigator is. We do hope to be able to build out a public-facing portal, but the evidence showed us at this point that it's the relationship that matters, and so that's the piece that we focused on. It is on our roadmap to build out that public-facing portal, though.
Could you pass that down to Don?
Hi, really interesting program. I'm curious, as you develop this, do you have a community-based governance structure that helps to advise you on direction and sort of how this is more than just a children's hospital program?
Yeah, it's a great question. And so FindConnect is one of the priorities on our strategic plan for the Center for Community Health and Engagement, and we have an internal and an external advisory board that are certainly helping me sort of shape the vision. I think that as we expand outside of the region, outside the state of California, we probably should consider having a national advisory board, but at this point, it's the internal and external advisory board of the Center for Community Health and Engagement at UCSF. If you're volunteering, Don, to be part of that national advisory board, I might think you as one of my officers.
Yeah, probably is.
I just had a question on the referral source. Do the referral source of community organizations that receive referrals, do they have any access to it? Are they able to receive any referrals or update their information? And then I have a follow-up question.
So each of the organizations that we refer to, we've worked out a referral mechanism. They can't actually see FindConnect yet, but it generates the referrals, and then they get faxed or sent over to the community-based organization.
Are there plans to include them so that they can have access to it?
Yeah, I think that would be wonderful.
And then the other question I have is on administration, sort of the rights and rules. Are there any entities right now that have external access to this, so that when you do these sort of rights and rules-based access, you can say, okay, this is an external party, they should have different rights under the plans, and I'm just curious.
Yeah, as far as that's concerned, we're able to abide by HIPAA compliance by removing the ability to enroll or view enrollments. So we can make very high-level user access that could include external, but that would be at the request of the organization themselves.
So it could include, in addition, the referral to, say, this team, so that we can go and get that information about who that may refer to them.
Yeah, so if I understand you correctly, you're talking about an external resource that can go in and input a resource into the knowledge base and only have that access.
Right.
Absolutely.
Yeah, and so we have you guys probably have this too, but within our hospital system, we have, we call it Children's Hospital Oakland ShowNet. And so when you log in, the icons will come up for logging into the EMR or accessing PubMed, etc. And so the plan is that we want the resources to be open free to everybody. And so there's a way just to link the resources on ShowNet so anyone can actually go and pull out the resources without seeing the enrollment information.
Hi, I've been doing a lot of head nodding. This is familiar to us in Colorado, the Hunger Free Hotline, which only works on one of the social determinants of health. And we're built on a Salesforce platform that's very similar. And do application assistance and have, I'm really nodding my head on the kind of resource refresh, because I know how much time that takes to have that really sharp. I'm curious about how you envision using the data to shape a public policy agenda. So in Colorado, we only have, 35,000 plus 40,000 households that are called the hotline, and we use that to kind of be our antenna up in the air all the time to shape our federal policy agenda, to shape our state level policy agenda, and to work on administrative rules, particularly for programs like food stamps and some of the state programs that people are saying, it can be a little touchy. How do you see, or do you see this, the FindConnect will now own a lot of data? How can that data be used to shape policy agendas, and will that be okay with the medical providers?
So, Sarah, it's such a good question, and I have a lot of big visions. And so one of my big visions is that we're going to be able to look at this population-wide data, both on a zip code, county, regional, state, and national level. And I absolutely hope that population-wide data on social determinants of health should drive policy. And I want to be able to use that evidence for advocacy, and I'm super interested in partnering with other people that can help push that agenda forward.
We have, 9 or so health systems in Colorado that are currently screening folks for hunger, and then they fax us a referral and we reach out. And one of the big things that we see, I know California's CalFresh or food stamp rates are very low right now. Colorado's have gone up a bit. So a lot of that was after ACA and the 3 open enrollment periods. We had a lot of hospital systems using med-only applications, and we've got this huge group of people that are on Medicaid that are eligible for food stamps that have no idea that they are. And so one of my big pieces would be getting health systems to use a full application so that we're not having to go back and duplicate work.
That's why I think that it was actually so novel that the food bank put out these RFPs for healthcare organizations to become enrollers. And we were really excited about that potential. And we were also actually surprised because we anticipated that we were going to be able to enroll so many families, because when you look at our rates of food insecurity, 57% of our families say they run out of food at the end of the month. And it became not as easy as we thought, which was disappointing to us, because we were all trained up and ready to go, and what we found is that the people that qualified were already on, and oftentimes the reason why the food didn't extend is because there were people in the home that they couldn't actually count as family members because they either weren't direct relatives, or they were over 18, or because of their immigration status.
And we do that too. We don't do enrollment because you have to have an interview, but we actually pay for a county, because we're also a county-based system like California. We pay for a county worker to be co-located with us, and so that they can do the interview to complete the enrollment, so we can go beyond the application assistance that you're talking about. It is. I mean, it's
a huge policy gap, right? Because if our families are telling us that 57% of them are food insecure, and yet we can't enroll them in the government food program, and we know that food insecurity is linked to poor health outcomes, I mean, that's a perfect example of how data can help drive a policy.
Well, and, you think about the average food stamp benefit is about $1.40 per person per meal. And if you're on a 2,000 calorie a day diet, you have to acquire about 500 calories with every dollar. And fruits and veg are 20 calories, maybe $1. So there's definitely good policy.
You said that was your first question.
Oh, sorry. I'll stop.
I'll wait.
Gentleman over here.
Thank you very much, Dana. That was a great presentation. I have a question as far as getting buy-in from your leaders and your providers in the beginning. You said that you had data that supported that. And I was wondering, is there some hard dollar savings or some return on investment to, further bolster the case to say why this is a need and why it's important for leaders to understand that, you just mentioned that these health determinants are affecting, our overall health of our members and our patients. So what type of data do you have? That's the first question. The second one is, what kind of process flows do you have as far as within the process of implementing?
So those are two good questions. When you ask me about buy-in, can I ask you, are you a clinician or from a foundation?
No, health plan.
You're from a health plan. Okay. So when I first started my research, we had gotten a grant actually from the Pritzker Family Fund in order to fund the study on the help desks in San Francisco and in Oakland. And there's an immense amount of time and effort that went into that study. And private funding, soft money is wonderful, but it also ends. I had gotten to a point in my career where I did have a lot of support from senior leadership, and it was time for me to actually start to push them that if work on health disparities is a value add to the academic rigor of your institution, then I need to become operational and no longer rely on soft money. And using physicians as catalysts and incubators for innovation and social change is very new for academic medicine, I think. And it took a lot of leveraging of my own social capital. And so I'm no longer paid on soft money to do this work. I'm actually operational within the Center for Community Health and Engagement. It still means that I need to raise money for the folks that I work with, but it was a big deal for an institution like UCSF to see the value add of research on equity. And I completely applaud them for that. Your second question is generating data on return on investment. And I think that this has been a process of believing something very deeply and then using the science in order to connect the dots. And so the first thought was that it is accessible and it is okay for us to ask hard questions to our families, right? The second thought is that when you ask those hard questions and you pair them with outcomes, when you pair them with interventions, you can actually improve child health outcomes. I think the next thought, and I was just talking to Anna about this, I don't know if she's still here, yes. The next thought is, so if you improve health, how does that affect the bottom line of the federal government? And so there's a triple aim, right? And that triple aim is three things, but one, you have to improve efficiency, you need to decrease costs, and you have to have high levels of satisfaction in care. And demonstrating that value add for products like FindConnect to actually satisfy the triple aim is what our next dot needs to be, and I'm really hoping that the partners in this room can help me figure that out.
Thank you for the presentation. I really like what you've been doing. I wanted to ask a little more in line with what this woman over here asked earlier around the opportunity for the partners in the community to get into the system, maybe to update their own data to show what the resources are. Hunger Free Colorado has an information system that they manage on their own. I wonder how many of these sites that you work with have an information system they manage alone or would like one, and how you're thinking about connecting to that information system, or extending this question about the resource in the community having access to it. How have any of these resources thought that I'd like to use your FindConnect as a place for me to chart what's happened for this client who's come in? So like it says legal up there. So yes, that text message can come back with a connection, but that might have been 7 visits for 7 hours. That would be important in terms of describing the types of resources that have been used in connection with a referral and how much we can aggregate to make your case about the needs. So I'm just trying to get an idea, where do you think on this trajectory it might be possible to address the desire of the resources to actually use the system to collect information about what's been provided?
So I wrote an article in Contemporary Peace in, I think it was November of 2013. And in that article, I called on our tech philanthropists around the country to really help us imagine a system like that. And the example that I gave in that Contemporary Peace article was right now when we have a family that comes in and they're homeless and sleeping in the streets or sleeping in the car, my staff has to actually call around to all the shelters. And I had imagined a system where the homeless shelters themselves could use the system in order to input how many beds they have for the night, and then we could look in the system and snatch a bed for a family. That's what I had imagined starting 3-4 years ago, and I would love to see that actuated. It is not yet because we haven't been able to get a Zuckerberg or a family like that to say, hey, how can we reimagine tech and leverage it for social impact? But I think it would be an exceptional thing to do.
I work for the Area Agency on Aging, and I'm a little out of my depth at Children's Hospital. We work with people 60 and over. But I think I can speak to your point about the return on investment. We've just completed an analysis of claims data versus the people we've served. So thank you, Kristen, she's speaking from Civic. And we found that our services in the Medicaid community, Medicaid pays about $5,000 less per year for the people we offer meals and transportation and addressing the social determinants in the older population. So as more and more data like that comes out over time, I think you'll have a better opportunity to speak with FindConnect and working to work with those community organizations that do provide those cost savings.
I do want to speak to the dyad though, right? Like there's this dyadic relationship that people don't often explore between the caregivers being older and the kids, and by supporting and keeping the caregivers healthy, you're actually keeping the kids healthy. And what we need to do is actually look at that data and how it affects the whole household unit.
We have the same problem in when we provide transportation to a senior to the doctor's office. Maybe their caregiver for that particular trip is under 18 or under 60, and we can't offer them a ride as well, so the person doesn't go to the doctor through that avenue. So we need to talk about that.
I have to say that a really amazing part of working with Dana has been this concept that she has, I call it a concept, of how do these things connect together. So when I come up with weird things, and I'm talking to Arthur, because of Arthur's have to talk to each other occasionally, the thing that is so interesting when I think about this is we call it the social determinants of health, because that's where this all started. It started with a health and a public health perspective. But I have this funny concept in my head that I call the social determinants of education. How are those different than the social determinants of health? As the chair of a foundation at a community college, I look at my community college students and I say, are they asking for the same kind of resources that come out of this kind of a situation with this particular tool? And they are. They may be reprioritized and they may be slightly different, but I have the sneaking suspicion that one of the next stops for this kind of software is going to be in the criminal justice system or in the education system, where all of the same kinds of resources are needed.
So I've had the opportunity to befriend Rob Smith, and Rob Smith is the managing director of the Campaign for Grade Level Reading and a VP at the Annie Casey Foundation. And he has chastised me before because he completely dislikes the term social determinants of health. And the term that he uses are the early determinants of school success. And they are one and the same.
Other questions?
I know that we have index card questions that we can get to as well, and I'm checking my phone for folks who are on the phone who might have texted. Heather Bernie? Wait, question, I knew you had to ask at least one question. I'd be disappointed.
I'm just intrigued by what you presented. I spent half my time working with a data team that evaluates early childhood programs, and one of those is the maternal infant early childhood home visiting program. And we also have a Colorado project launch that addresses early childhood mental health needs. And the question about resources continually comes up. So we're not statewide with these programs. We have high-need communities that have been identified, and I think, I just felt a lot of validation in what you said is what we're finding as well, where some of the providers, home visitors, are afraid to ask the question because they don't have a resource to which to refer patients. That was just commentary. Thank you for what you're doing. But my question is a simple one. So this closing the referral loop, I'm just curious about what's the completion rate of people actually texting back whether the referral closed?
So when we actually researched closing the loop with families for the purpose of our trials, we did phone calls. We didn't use text. And so the evidence that I have is based upon using phone calls. And we made at least, shockingly, right, this is such a low-cost intervention. It only took, on average, 2 phone calls in order to have a statistically significant difference between the control group and the treatment group in child health outcomes. 2 phone follow-ups, that was it. Now, as for the texting system, this technology is new, and I think that we're going to have to make a case for it and see how it compares to calls.
A lot of times, we don't get as far as actually being able to do the clinical measurement for some of these families. At the same time, we're not able to invest resources to do those phone calls to see if the referral is actually closed or not. So I'm really intrigued by the texting solution.
Hi, thanks for the presentation, it was great. What worries you about what's happening now? This is new for your group, and what things are you seeing as potential barriers into the future, scalability, things like that? I don't know what it is. I want to hear from you.
There's a lot that keeps me up at night. I think that what we created is really a jewel, and it's really something special. What keeps me up, though, is, and it was a gentleman that asked this question who was sitting over there, about how is it that this is actually going to create national change? How is it going to get on the agenda of the policymakers, both locally in the state and nationally, to make it mandatory that we ask these questions? I mean, I feel like at the end of my career, I would be amazingly satisfied if it was just a given that we asked about determinants of health and that these priorities were simply as important as making sure that the vaccines were up to date. And getting from where we are now to getting this to be such a simple shift in our paradigm of medicine that people don't even remember the days that we didn't ask the questions.
Can you give an assessment of what you think the caseload could be per navigator for this type of work?
Absolutely. I've thought about that a lot. And so relationships take time. Building trust takes time. And this is truly about partnership. And so if you look at a typical week within a primary care setting, there are 10 4-hour blocks of time. Obviously, if you're in the emergency department, I think we calculated there are 21 4-hour blocks of time. And each navigator, realistically, can enroll up to 4 patients per their shift. And so depending upon, we have 2 navigators typically working at a time. And that seems to be what their capacity is. About 4 new enrollees during a 4-hour shift, about 1 per hour.
And the follow-up for that type of work, can they keep that as part of their caseload?
So for our navigators, we have them in clinic for, they each do about 7 shifts. So out of the 10, they're there for 7, and then they have 3. One is that we're just closed for our staff meeting, and then the other 2 are time for them to do follow-up.
So part of your discussion has been, or the questions have been around how does the community help support this work or update, and then the portal facing that is part of what you're hoping to develop. In a lot of our work that we're trying to link patient navigation and utilization of tools such as this to help them in their work. I think one of the things that I constantly hear are people from the community who are navigating folks who end up into a hospital-based system and want to figure out how can they be a part of the care team, just because it's really, a lot of the navigation or community health work initiatives really include them, and they're usually the ones that are sometimes helping getting people eased in. Have you guys explored, or what are your plans for even navigators who might be peripherally connected to your work, integrate with this system as kind of really when you think about the process of navigation and, the continuum and sometimes passing the baton? Have you guys experienced or utilized community navigators or community health workers in your work to utilize this portal yet?
So I could say yes on 2 accounts. So we've been in conversations with our home-based case visitors, and they definitely want to use the tool. And so we hope to be able to onboard them in January to use the tool. I also want to, now that we are sort of at this stage, I want to be able to start to onboard our discharge planners within the hospital for our primary care patients that get hospitalized, and that's where this iPass system that Matt was talking about is so important, to be able to pass the family on to the discharge planner, who then can very quickly pass them back to the primary care navigator.
Andy, do you or others in the audience have an idea about how you see that maybe integrating or aligning if we have this system available to us here?
So there's one model that I think is exceptionally novel in the adult population is Linda Stephanov and her team with the Native American Cancer Research Corporation have actually looked at opportunities where there are HIPAA agreements that are made with her Native sisters who are navigators with all the area local hospitals, and they really, become part of that network and that thread. And so therefore they really become a part of the integrated team at large. And I think that's a process from the navigation, in terms of our development of team-based care with community and cultural connections. But I think what everyone's looking for, quite honestly, is a tool like this, that then once people are out of maybe a hospital-based system, how do they continue on, that allows maybe community-based navigators or the like to continue to work with people who might be. And I know that, there's probably a general balance of when it just becomes too much or too little, but I think what happens is that, a lot of people end up becoming chronic care conditions and management. And if we could utilize that sort of workforce as this sort of tool for management, reduction in ER cases, reduction in, hospitalization and all these other pieces. So I've seen models that work really well that we don't have yet. I think there's a system that bridges nicely, and I think what you're looking at least has a huge foundation to be that. And then it's going to tie to health outcomes, I think could be really big in terms of looking at those groups, showing their value and work in the community as well.
And more into sort of tag on to what Andy is saying, what we have here in children's is a program that is funded by the Cancer Cardiovascular Chronic Pulmonary Disease folks over at CDPHE, is a navigator group that goes into the community and works with kids in their schools. And they work primarily around asthma issues, but what they've discovered is the same thing that Dana discovered. If you go in and you work with a group around a particular issue, it's not that issue that they stay on, right? They become engaged in a lot of other things, and that's what our navigators find. And that's one of the reasons that we've been working so hard to make this work, is because I think our navigators could take this into the schools and use it in just the same way that they would be using it here in the hospital.
I just want to say before we have more questions, but if anybody does have to leave, there are some sheets out in front. I'd love for you to put your name, your organization, and your email, just to make sure if you want to. We'll send follow-up from today. There's some studies, there's a JAM study that was just published that David did, and some other things, and we'll keep you posted on things. I just want to make sure that for folks in the room who have not maybe previously been engaged in these conversations, I just want to make sure I have your information. I didn't want to forget to say that. Other questions? Where the cards are, I thought I had the cards, but I think that's the right one.
How much does the platform cost? Any reportable results or improved
Overall health.
overall health? Thank you. We'll start with those. Okay, so overall health and program costs. We talked a little bit about internal costs, but
Overall health, you said to start with. So I think that the most recent data is in that article that Lauren referred to, that you guys are welcome to look at that data.
I'll make sure to send that article out to folks.
And I had alluded to the fact that we are just launching into our next research study where we're looking at the FindConnect system and pairing that with some more mental health questions and correlating that to children's biophysical profiles. And so I will have that data very soon. And then the question about costs, Matt.
As far as costs are concerned, as Dana mentioned, we've sat up late nights and thought long and hard about our approach to the cost of this platform, understanding how important it is to get these types of tools and innovations in the hands of organizations across the country. So we're going to be taking an innovative approach to the cost in that we would be able to assess each organization's needs as far as the customization of the platform, and then look at their team size and understand how much training would have to go into it. So then we'll be able to derive a cost to customize the platform and set up proper training either for initial training or training trainers at the organizations. So what we've thought about is assessing a bucket of hours for each organization that is customized to their needs, their size, their customization of the platform. So, we had a lot of conversations about it, and it's an ongoing conversation, but, we do understand that this is an incredible tool that needs to get out there, and cost can be a barrier at times, so we've thought a lot about that.
We had hoped to figure out a way to do some collaborative funding to seed the development of a common platform here that could be used by multiple organizations, not just by one hospital at a time or one system at a time, but could be used by patient navigators, community workers, and FQHCUs. So the cost associated with that has to do with staffing folks to keep those resources up to date. We're partnering with folks who are already doing that and augmenting those processes. So there has been some thought around how might we fund that. And then internally, in various organizations, we have to figure out what does that take in terms of learning collaboration or training or gearing up to do that kind of work. But we've been trying to figure out how we might support that from a grant-funded and collaborative-funded perspective so that we can feed that here to help that process get started. And again, those conversations are in process. Has the tool improved client, patient, family satisfaction?
Yeah, so one of the FIND program in and of itself, one of the matrices that we looked at was patient satisfaction with services rendered, and our satisfaction rates were like through the roof, like about almost 98%. So I can assuredly answer yes to that question.
I think one of the most fascinating and funny and heartwarming stories that you told us over the time that we talked to you, Dana, was about a family that came back to the hospital to talk to the Project Find folks, not because they had an appointment with a doctor or a nurse or anyone else, but because they wanted to come back and get more resources.
Families are, for those of you that work with our families, they are amazingly kind and gracious and open and receptive, and it baffles me. Like, I go to these meetings for the NIH because my other hat is that I do these NIH site trials for asthma, and they talk about how hard it is to recruit minorities into research, and I just sit there like, I don't even know what you all are talking about, because that's not the families that I work with. I find that our families are always kind, and even when we fumble, we don't ask the right question. They are so respectful to us, so kind, and I found that families are engaging in my research. We do incentivize families, but the monetary incentive is so low that there's a true desire to improve the community and to contribute to our scientific knowledge.
This question is about how often the resource base, the knowledge-based resources are updated and how. We spent a lot of time hearing about that from Health Leads in some of our early conversations. They do it every 30 to 90 days, and know that that's a really important metric.
Yeah, and so when you look at our knowledge base, every resource has an expiration date that we've thought long and hard about the rules. And so, for instance, for summer programs, they should expire at the end of the summer. And then there are federal benefit programs like WIC, SNAP, CalFresh. Man, you all know how hard it is to change those eligibility requirements. And so those, we feel quite confident that we can refresh those once a year. And so for us, it's looking at the category of the resource and just thinking smart about it and creating lean standard rules.
And that's one of the things that we thought a lot about here is how would we staff those resources, who might we partner with to make sure that those are staffed in that way. The assessment does not ask whether the family might need and be eligible for financial benefits or other financial resources like SSI, disability, emergency rent assistance. Is there a reason for this?
So there is a benefit section. Matt, just because of time, he chose not to go through that, but we do ask about benefits.
So I just wanted to ask, how many sites are similar to work that Lauren and Arthur are doing in Denver area or in Colorado? How many sites across the country are looking at what you're trying to do? You mentioned earlier a national initiative. You're looking for partners. How many sites are there that might be opportunities for dissemination? And how are you trying to organize so that dissemination might go more smoothly than you've had to kind of build it from scratch in the San Francisco area?
Yeah, so the question was about the strategic roadmap and how we plan on moving forward and what sites are involved in the project. So, as I had said before, when I went about creating this, it was because I wanted to create a tool that I could use within my home institution. My big goal at the time, it wasn't to create a national product, and my intention was how do I just serve my community better. And so I have a huge stake in making sure that this spreads across UCSF. But in terms of our external partners, Colorado, you guys have been awesome, and working with Arthur and Lauren, I'm super confident that we're going to be able to make this happen here. And this is going to be our first statewide site, and I think that it's a fantastic place because all of you are on the precipice of really making real change. And so I think this is going to be a great demonstration state, and then jointly we can decide how we want to roll it out to others. The three of us, we are doing demos often. So we'll just continue to do those and see what happens.
Does anybody on the phone have a question? There's only a couple of folks on the phone. I think I've asked what they needed to. Any thoughts from all of you on what you'd like to see happen in Colorado or next steps? I mean, there's ongoing conversations, I think, until we have some additional conversations with the Colorado Health Foundation that will help guide us. But it's important that we hear from, on an ongoing basis, from all of you, all of the places that are trying to do this, Project Launch, the Research and the Raise, Help Me Grow, Denver Health, Children's Hospital, University Hospital, the AHCs, all of us are trying to figure this out. So anything else that you might wish to see convening work, we'd really like to hear about that. So any thoughts about Colorado-specific themes and or final thoughts for Dana and her team? Yeah.
So I think the challenge with this kind of work is, and it's been hinted at in some of the questions and comments, is I'm going to use jargon. I'm going to say it's applications versus infrastructure. And the fact that a lot of folks have their own applications that they're using, but we don't have an infrastructure that allows those to be able to communicate. This is an awesome application for a healthcare setting. It's probably okay for some social services organizations, but they probably already have something they're using. And so the question I'm asking myself is, how do we build the infrastructure that allows these awesome applications to interconnect, exchange information, and that's the big question in my mind. I'm bringing some folks to Colorado from the UK that have worked on this problem in northern England at a community level. I'm hoping to convene a meeting with them next month when they're here, and I'll work with Lauren to get information out to folks about that.
Art, do you want to say anything about that question?
So we were fortunate to be funded by the CCPD grant from the state to create a system that will allow for referrals to happen. And the first step in that process is getting an accurate registry or inventory of community resources and figuring out how that can continue to be maintained and updated. So we're working with the 211 system in this first year of the project to understand what are the needs of the resources, what are the needs of the referral sites and of the clients, and how that whole business process would happen to build out a community resource inventory that could be queried by an electronic health record. So in my organization, I think we'd like to get those social determinant questions into the chart, not in a separate system, and then allow the chart to have this conversation with 211, and then have a conversation as well with these community resources on referrals and how it's done, and close the loop, as someone had mentioned, give feedback. So that's a project that's beginning, just started in October, and we have a couple years to work on that.
Any other questions?
In response to your question, Don, I just wanted to mention that we, as a work group, have spent literally thousands of hours over the last year and a half doing outreach with various organizations, including some of those statewide resources and government assistance, health and human services, things like that. And we've got substantial interest from them to figure out that infrastructure piece. So there's a lot of interest, I think, from both sides to figure out how to make this all come together. So that's definitely something that we've been putting some time and effort into as well. That's a great question. The big hairy questions that we still don't know the answers to are particularly the complexity of statewide systems are still what we're handling a lot and often.
All right. If we don't have anything else from you folks, I would like to thank you for coming here, children. As you can see, we have kind of an amazing place that has a lot of conference rooms and sort of get underutilized by the community, so I'm glad the community has come to Children's today, and I would like to thank all of my team members. Dwayne, I don't think we've heard anything from you today. Yeah, Dwayne's been very quiet, and Lauren, and I think one of the great things about working with Kristen has been just she brings her team at the same time she brings herself, which is kind of fun too. So thanks to you guys for everything you've done to organize today, and most grateful for you to be here, Matt, Jeremy, and Dana. I think one of the things that really has been fascinating, as I said, as we talked to you, has just been you have this incredible mind for just communicating this stuff and getting it across, but as well, you bring all of this knowledge to the table, and we really thank you for coming.
Thank you for having me.
We really hope Dana's going to go on to work with ex-presidents and things to
Make this a national issue.
Yes.
Please do put your name and email on one of the sheets out front. And thank you all for coming. And we're here. We have time. If any of you want some time with Dana, Jeremy, or Matt, or any of us, please feel free to stay, or please feel free to email us as well. Thanks. Oh. This was also recorded. We didn't know that was going to happen until just a few days ago. So if anybody would like the recording or want to share it with folks, we can do that as well. Thanks for folks on the phone for joining us, a couple of you that did. And thank you